Okay, so my name is Camille Herron, and I'm here as the, I was going to say token nephrologist, but I'm the jobbing nephrologist, okay? And I have stuck to my title, which was given to me as caring for people living with chronic renal disease to the end of life. My talk, I think, is going to be quite practical, and I'll just give you some of my experience. So I've been working, who am I? I've been working as a nephrologist in the field of nephrology for over 20 years, and I've been a consultant based at Antrim Area Hospital for over 10 years. So just a bit of geography, just in case anyone doesn't know where Antrim, I put it on an arrow there. Antrim's about 18 miles sort of northwest of Belfast, and there's a picture of our dialysis unit here. But we actually cover quite a large geographical area, and this can be relevant sometimes when you're thinking about patient choices and where patients are going to have to travel to when they're making decisions about dialysis. So we actually cover the area right up to the north coast, Giant's Causeway, and over into Tyrone as well, and sort of some of the outskirts of Belfast. So what am I going to talk about? I've divided my talk today into three main areas. Not everybody in the audience has a renal background, so I'm going to speak a little bit about chronic kidney disease and definitions of that for you, and talk a little bit about life expectancy. I'm going to mention the symptom burden for patients with chronic kidney disease, but Professor Watson this afternoon is going to focus on symptom control, and I'll leave that to him. I'm then going to talk a little bit about my experience of palliative care within the field of renal medicine. Symptom control, again, I'm not going to focus on, but I will talk about disease trajectories and also prognostic indicators, trying to identify those patients who might be in the last year of life, or however you want to define end of life care. And then just specifically some of the things that we have done within our own service to try and develop the palliative care input. And I would have to say, what I'm speaking about today, I'm speaking on behalf of a team of people. I'm representing them. Some of the relevant team members are in the audience. I will point them out to you in a photo later on, so you'll know who to nab at coffee time, okay? All right, so just talking a little bit about kidneys. So most people look on kidneys as a waste disposal system. It's a bit yucky. They don't like the thought of urine. The taxi driver, I think it's fair to say, wasn't very impressed. It was a bit of a, the conversation kind of halted, didn't it, at that point when we mentioned kidneys this morning. But the kidneys are actually a very sophisticated organ, and they do a lot more than just getting rid of your waste products. So, for example, they're involved in salt and water balance, electrolyte balance, acid-base balance. They have a number of endocrine functions. And the reason I highlight this is because when we're talking about sort of providing symptom control and care for patients with kidney problems, it's not just about getting rid of waste products through dialysis. There are lots of other aspects of care and management that are important. So in terms of how we assess renal function, you'll all be aware that we do a UNE test. We get a creatinine level from that. From that, we get an estimated glomerular filtration rate. So within each of your kidneys, there's about 1 million of these little filtering units called glomeruli. And we can use the estimated glomerular filtration rate to give us an approximate percentage kidney function. And when we take the percentage kidney function, we can stage chronic kidney disease depending on what the figure is for that. So if we take all stages of chronic kidney disease, about 5% of the population have some type of chronic kidney disease. But a bit like talking about areas of specialism and generalism, in general, for us as nephrologists, we look after patients whose kidney function usually would be less than 30%. Those are the patients that would be coming to our clinic. And patients, on average, start dialysis when their kidney function is about 10% of normal or lower. So those are rough ballpark figures for people who don't have the renal background. In terms of the pathways for our management of these patients, when patients are referred, look as though they are going to need help with their kidney failure, they get referred to what we call our low clearance clinic. Usually we take patients into that clinic when the kidney function is about 20% or lower, and it looks as though it's gradually getting worse. So these are patients in whom we need to consider whether they're going to need what we call renal replacement therapy. Usually, it would be a period of about 6 to 12 months where we work patients up for renal replacement therapy. You will be aware that the best option if you've got a serious kidney problem is to get a kidney transplant. But a lot of our patients have significant comorbidities, cardiac disease, severe complications from diabetes, other types of vascular disease. And in fact, of our dialysis population, Antrim, we have an older dialysis population, but probably less than 20% of them are suitable for transplantation. So you see transplantation is down there as the option on the right. But for the vast majority of patients, we will be considering what type of dialysis therapy would be suitable for them. I'm not sure if I have a pointer or not, maybe not. Once a patient has established organ failure, even if they get a transplant, they're going to be on our books for the rest of their life. So now, having spent over 20 years in nephrology, I have seen quite a few patients who have actually progressed to needing end-of-life care. So whilst that maybe wouldn't have been the focus for me as a nephrologist initially starting out, it very much is something that I'm much more aware of. And I think one of the important things that I've learned about palliative care is the importance of getting that end-of-life care correct. So established renal failure or the need for dialysis is associated with a poor prognosis. So about 6% of patients who start dialysis will actually die within 90 days. So they'll just have been very ill with other things. And 1 year survival is about 79%. These curves are just showing you sort of death rates for patients on dialysis compared with the general population. So the patients on dialysis are your white dots at the top, and the general population is in black. And you can see that there's actually an exponential scale on the mortality. And if I did have a pointer, what I would show you is that the life expectancy for a person of 40 who ends up on dialysis is about the same as an 80-year-old in the general population. So I have to say that the surprise question doesn't really work for me, because I've seen lots of young people who have died. And if you've been looking after a person for a period of time, you actually become less objective in terms of actually being able to think about what their prognosis is. Sometimes can be a bit of an eye-opener when I go into ICU to try and get one of my patients in, and someone else looks at the patient and their list of comorbidities and really saying to me, I think you're being unrealistic here. We contribute our data to the UK Renal Registry, so we actually are able to draw up curves on what life expectancy is at various ages for patients starting dialysis. So an average patient starting in Antrim is usually about 66 years of age, and their life expectancy is probably going to be between 4 and 5 years. So funny enough, in nephrology we love figures, but in actual fact we're not very good at discussing prognostic figures with our patients. We seem to be a little bit uncomfortable by that, and that's something I think that we need to explore. So it's unusual for a patient to ask us when they're starting dialysis, how long do you think I will live? For a cancer patient, I would imagine quite often with their oncologist they do say, how long do you think I'm going to live? So sometimes it can be helpful to give the patient this information. I suppose for me as an individual, if I thought I had only 4 years to live and someone had that information, I probably would like them to share it with me. So that's probably something we need to explore. Now, yes, this one is working. Yeah, this is really just a bar chart showing you that in actual fact, survival on dialysis is probably lower. 5-year survival is probably lower than for a lot of the common diagnosed cancers. So I think this is really highlighting that whereas we're good at thinking about palliative care issues with cancer, we do need to take that information and expertise through to other chronic diseases, and in particular with renal, we do know survival is actually worse probably than a lot of cancers. Okay, symptom burden I'm not going to focus on, but just to say the patients who do have chronic kidney disease do not feel well. They feel generally very ill, and they have sort of tiredness, they fatigue easily. In fact, most of their symptoms don't actually relate to the fact that they're passing less urine. They might notice that they pass more urine at night time. So I think it's easy enough to understand this, because basically what they're experiencing is a build-up of waste products. And as I explained to the patients, these waste products are circulating throughout their body. So it's no wonder that their whole body feels unwell. In terms of dialysis, up north dialysis costs about £42,000 per year, and as you know, we're meant to calculate things in terms of quality adjusted life years. So people who are on dialysis actually don't feel well while they're on dialysis, so if you actually do the sums, it works out even more expensive in terms of qualities, and in fact we don't usually do the sums. One thing is that if a patient decides to stop dialysis, usually they'll be dead within 7 to 10 days. So usually we're not really thinking about, oh, can we justify the cost of continuing dialysis for you? It's too high stakes to do that. Okay. Oh, my goodness, where do we see? Don't know what I did there. But just to point out, and I'm sure Professor Watson will be focusing on that although pain is not a symptom of chronic kidney disease, 60% of our patients do experience pain, and I'm sure that will be explored later on. Okay, so that's just a little bit of background about renal disease and what life expectancy is if you end up on dialysis. In terms of moving on and talking a little bit about my experience of palliative care within renal medicine, the first thing I should say is that when I trained as a doctor in the 1980s, there was absolutely no palliative care medicine on the curriculum. So in many ways, I feel that one of the things that has changed most in medicine over my working life has been the introduction of the importance of palliative care. Now, as a nephrologist, whenever I get stuck on a difficult electrolyte problem, I go back to first principles. And sometimes you do get a bit stuck on a palliative care issue with a renal patient, so I'm just going to quickly just go through what I think are the first principles for me. So, going back to thinking about person-centred care rather than disease-centred care, thinking about the focus on the quality of life, thinking about trying to recognise dying. And this can actually be quite difficult for us as nephrologists because we can keep people alive on dialysis. That doesn't mean to say that we should keep going with dialysis. It's very rare for me to actually write down renal failure as a cause of death on a death certificate because usually something else has happened. But it can be interesting because I do remember one instance where actually a patient's husband said to me, "We have to let her go," and I realised he was breaking the bad news to me rather than the other way around because I did not actually recognise that the patient was dying. Okay, so perhaps that is an example of adopting an honest approach to uncertainty, and this is something I have learnt from my palliative care colleagues as well, and I appreciate Dr. Macaulay, I'm going to name, who's our local palliative care physician, that as a nephrologist I always want to give an answer to a question, but that sometimes giving an answer is not the correct approach. It's sometimes better to say, why are you asking that question, and take the conversation down a different track. Okay, and these are complex issues, and if I had to give you just one top tip, it would be make it a complex issue for the team to deal with. So there's a lot of support to be had from colleagues. Okay, so there is a document, an NHS document, which was published in 2010 looking at end-of-life care in advanced kidney disease, and it gives a number of instances where you may wish to consider end-of-life care, and I'm going to talk about some of these, but just to run through them, if you've decided on conservative care management, so if you've decided dialysis isn't appropriate, when patients are deteriorating despite dialysis because of their comorbid conditions, if there's been a new illness, for example, a severe stroke or new diagnosis of malignancy, and maybe if you've decided to withdraw dialysis. So what about supportive care? So supportive care is called different things. In the last slide it was called conservative care in the end-of-life document. But this is the concept that for some patients who have other serious illnesses, that actually putting them onto dialysis when they develop renal failure may actually make very little difference to their life expectancy. I've said to you that there can be travelling problems for patients coming for dialysis, but dialysis can be very difficult for some patients, particularly if they've also got cardiovascular disease and they've got instability with their blood pressure when they're on dialysis. And in some circumstances, actually, no dialysis may give a better quality of life than dialysis. So for every patient, it is important, particularly if it's a patient who's got other significant comorbidity, to actually think about whether it is appropriate to go ahead with planning for dialysis. In terms of disease trajectories, we see all of the disease trajectories, so I wouldn't actually say that there's one of these that is typical for renal failure. Now, for organ failure, which is curve C there down at the bottom left, I think that applies more to maybe cardiac failure or respiratory problems, because you've got to remember that we're dealing with the organ failure if we're giving the patient dialysis, okay? So we wouldn't necessarily see that there would be exacerbations of their renal failure once they're on dialysis. But certainly we can see exacerbations of other comorbid conditions, so we can see that. I have to say sudden death is a common cause of death in dialysis patients, and that relates to probably cardiac arrhythmias and occult cardiac disease, and it's not an uncommon situation for a patient just not to come back after their weekend off dialysis. And certainly there's some ongoing work sort of suggesting that the 3-day gap that we have for patients who are on hemodialysis is probably a risk factor for that. Some of our patients will develop other illnesses such as curve B, and they will have sort of maybe a predictable end of life. But a very common scenario is curve D, where patients just generally become more and more frail. And sometimes we have registrars from other specialties come in to spend a bit of time for us, for example, from care of the elderly, and they take a tour of the dialysis unit and they are totally shocked at the calibre of the patients who are receiving dialysis. And what I say to them is, well, look, this is not how they were when we started dialysis or made that decision. Obviously, they've deteriorated since we've started dialysis, and it then becomes a very high-stakes decision, even for a patient with dementia, that you would decide to stop dialysis because they'll be dead within 7 to 10 days. You've got to think about the impact on the family and the carers. And it can be very difficult to judge someone else's quality of life, and almost the fact that patients continue to keep coming for dialysis suggests that they are in agreement with it. And I would have to say that although patients will often say that they don't want to go to intensive care or they don't want to have CPR should they have a cardiac arrest, for patients who are established on dialysis, dialysis is one of the last things that they want to give up because it's become a way of life for them. So what do our patients die of? Cardiac disease and other types of vascular disease are very common. Just to compare it with, this is sort of breakdown from, again, the UK Renal Registry to which we contribute. But if you compare it with causes of death in the general population, you can see that cardiac death and infection are more common. Malignancy is actually a less common cause of death, and that may be because perhaps in the past patients who did have cancer weren't accepted for dialysis if it was felt that their life expectancy was poor. So in general, a lot of nephrologists would be reluctant to start dialysis if it was felt that someone's life expectancy was less than 6 months. But again, you would always want to consider what the individual situation is, because a few extra months for a younger person might be actually quite important. Okay, the majority of as I've said, the majority of patients with chronic kidney disease will die of a non-renal cause, but the renal disease does contribute to that. And I'm just going to give you a few examples of what goes wrong with the body when you've got chronic kidney disease. So you'll be familiar with some of the acute effects of kidney problems. So patients can develop fluid overload. Of a chest X-ray there showing some pulmonary edema. They can develop cardiac abnormalities, particularly if they've got problems with hyperkalemia. I often think a cardiac arrhythmia from hyperkalemia, if you're going to die, would not necessarily be a bad way to go, but I don't know. They can also develop other cardiac problems, fluid around the heart. They can develop twitching, seizures, but usually if a patient has been on dialysis and we withdraw them with dialysis, what will happen is that they'll gradually go into a coma and become less responsive in that way. Okay, so for the non-renal people in the audience, kidney problems also lead to abnormalities in your bone metabolism. You get an elevated phosphate level. You can develop bone formation in places where you shouldn't. This is a bit of calcium phosphate around a shoulder joint. As you could imagine, that would be very painful. But the problem is that if you develop calcification in your blood vessels, that's actually going to cause more types of problems. This is just a plain X-ray of the hand. And again, I don't have a pointer, but if you look, you can see calcification of the radial artery. And once you stand back, you can actually see calcification of practically every blood vessel in that hand. Okay. You can also get severe types of calcification within the small blood vessels. I'm just going to give you an example of this. This was actually a young girl we had who was only 29. She'd had a failed transplant and she wasn't suitable for another transplant because of the type of kidney problem that she had. She developed very painful condition in her legs known as Calciphylaxis. These rather benign lesions, but when we see calciphylaxis in a patient, it usually means, even for a younger patient, that they're going to die. So her ulcers eventually broke down, and this is extremely painful condition, and this has been one of the most difficult palliative care situations that we would have, because we have a young patient, we know they're going to die, and we also know that they're in a lot of pain and it's difficult to manage. So some of the issues can be particularly challenging. But as I've mentioned, some of our patients just gradually become more frail, they become malnourished, they develop low albumins, which of poor prognostic indicator. And what we see is that they start getting circulation problems that become increasingly difficult to deal with, not necessarily with the heart, usually it's at the other extremity. So we see patients who develop peripheral ulceration where we're gradually chipping away at their lower limbs. And we see patients who develop cerebrovascular disease, either there's a large stroke or perhaps the image on the right is just showing you lots of small infarcts, which will contribute to multi-infarct dementia, which we see quite commonly as well. So, as I've said, I don't find the surprise question particularly helpful because a lot of my patients at this stage have died. So what do I find helpful in terms of thinking about whether a patient may have actually a worsening prognosis? Well, I think when I start to see a patient who's had repeated hospital admissions, there's a bit of a light bulb goes on. This patient's been in hospital 3 times in the last 6 months. I need to think about where we're actually going with this patient. Cognitive impairment obviously is worrying. Reduced functional capacity. Now I have to say, as the doctor in the unit, I'm not always very good at picking up on this. There's one of my patients who I've been going to see, and we've been discussing different things about pain. And then one day I happened to go into the unit and I actually saw him walk from the weighing machine to his dialysis couch, and I realised how frail he was, which I hadn't really picked up on because normally I would just go and see them when they're actually on their dialysis. Quite often when I realise I need to I don't know why, but I go, I need to speak to those relatives. That usually means I'm worried overall about what way things are going. That can be a problem because sometimes if a patient hasn't been actually an inpatient much, there hasn't been that much opportunity to actually have to speak to relatives. So sometimes it is necessary to bring them up specifically for a conversation. Patients who are losing weight, patients who have persistently elevated inflammatory markers without being able to find a cause for that usually means prognosis is worse. Okay, so then just quickly to move on to how we've tried to develop the service. So I think the issues that we have tried to look at are thinking about symptom control, trying to think about some of the decision making, and particularly when should we not start dialysis and when should we discontinue dialysis, advanced care planning and end-of-life care. Dr. Murtaugh's work has previously been mentioned. So she has done a study looking at, I think, elderly patients, and forgive me, but I think she might have defined them as over the age of 75, which is not particularly elderly to me. But anyway, elderly patients, and looking at patients who chose dialysis and patients who chose not to have dialysis, and what the life expectancy was. And so from this curve, you can see that patients who have chosen dialysis appear to live for longer than patients who don't. But if you actually take patients, and these are small numbers, if you take patients who have 2 comorbidities, so that could be a bit of ischemic heart disease and a bit of COPD, which is a not uncommon combination, you actually find that the patients who opted not to have dialysis lived as long as the patients who opted for dialysis. So for those patients, you need to be honest when you're discussing dialysis options and say, well, you may not actually live longer as a result of this treatment. Okay, so we have developed a conservative care part of our pathway as an option for patients who have progressive chronic kidney disease. So how does this work? So we now, as part of our low clearance clinic, have what we call a supportive care clinic. And this was set up in 2010. And the clinic really has been developed by two people who, again, I'll point them out in the photo shortly. A palliative care consultant, Dr. Jane McCauley, who, as I say, is in the audience, who was generous enough to lend us her expertise so that we could set up this clinic, and also our renal nurse specialist, Louise Sloan, also in the audience, who coordinates our low clearance clinic and who was actually had the interest and enthusiasm to develop this part of the service. And then we as nephrologists rotate into this clinic, and we also usually have a dietitian, and we can have input from social worker and pharmacist as needed. So what difference what do I think is different about the supportive care clinic? Well, I think perhaps we have more thoughts about what prognosis is for the patient. I do think that there's much better attention to symptom control. So quite often as nephrologists we look at the numbers and see what things we can correct, like maybe the hemoglobin or the phosphate, but maybe we're not so good about asking the patients about their itch and actually how they're feeling and just generally functionally how things are. So Jane has actually introduced functional assessment of the patients who are attending the supportive low clearance clinic, and I think through the training that we've had and the interest that have developed that we're now got a better awareness of the support that we should be considering for our palliative care patients, in particular psychological needs, spiritual care, social needs. So I think I'm still getting my head around holistic care, but hopefully we're getting there gradually. We've also been able to pick up the skills that we need to develop, for example, communication skills, and also we've also given a little bit of thought to what we should be thinking around bereavement support for patients when they do die. So in terms of the outcomes from the clinic, over the past, I think this was 3 years of data that I'd taken, we have had about 39 patients. Median age has actually been 88, but there's been a range. And these are patients with advanced chronic kidney disease, median eGFR 8 mils per minute. Currently we have about 14 patients, and that's about 7% of our low clearance population. So it's not a large proportion of our work, but it's an important bit because it's important to actually provide the option of not having dialysis for patients, but to still let them know that we're going to follow them up and provide symptom support and other care for them. And sort of once we've been able to get to know a patient, work out what the issues are, we feel more comfortable with them maybe having them under virtual review where we can look at their figures on the computer and maybe either contact the patient by phone or liaise with the general practitioner. 24 of the patients have died, and you can see that there's been quite a range of follow-up, so 14 to 803 days. So you can't really predict how long a patient is going to live. We've done some primary, a little bit of analysis on the figures, and we've looked at the place of death. So 45.5% of patients actually died in their usual residence, be it their own home or a nursing home. And I feel that more of those patients have died in their own home as a result of there having been a good plan in place and the issues having been considered in advance. Some of the patients were hospital inpatients, and some of the patients were actually within this specialist palliative care unit. And I see those figures don't add up there, so I'll have to come back to those again, do they? Maybe they do, 87. Oh, they do. That's not so bad. Right, okay. Right, so here we are. Here's the all-important photograph. So what's the most important thing? The most important thing is to get the team together, okay? So it's good for everybody's morale, but also you will bring in the expertise that you need. So Louise is on the left, and then we've got one of our specialty doctors, our pharmacist. This is Jane. She stands like the guardian angel, I think, looking over us all and keeping us right. And she's our moral conscience and all sorts of things, yeah. So when I forget to ask about the pruritus and the itch, and I hear Jane in the room next door asking about it, I go, oh dear. Right, and then two of my colleagues, Dr. Cunningham and Dr. Mullen and Jerry Totten, who's our unit manager. And there are other people, but those are the people that were there, unfortunately, when I got out my camera. Right, for them, unfortunately for them, luckily for me. I think the next area that we want to develop is probably our advanced care planning. So I think we've developed the service well in terms of what we're doing at the low clearance clinic, but we actually now want to take that expertise into our hemodialysis population. And I think we would, well, I'll tell you how we're developing that, but we do want to think more about place of care and advanced care planning, and also how we document the communication that we're having with patients. I'll just quickly go on. So, what have our developments been? Well, what are we planning to do in the future? Well, we've set up our supportive low clearance clinic, which I think is now well established, and Louise is now considering, and has, I think, on occasions, considered home visits. And Louise is also liaising with community teams and has been trained up in their communication systems as well, and electronic systems. We meet as a team once. We initially started meeting monthly, but we now realise we just meet about every 2 months, and we have a little MDT. And what do? We reviewed recent deaths and what learning there has been from them. We discuss what difficult cases we do have at present. We discuss inpatients that we have in which there are end-of-life issues. We also sort of discuss those patients who we think are deteriorating and sort of highlight them amongst the team. Someone has said that staff training is one of the most important things, and a number of us, not myself because I missed my dates because I need basic communication skills training, but anyway, a number of the team have gone to the advanced communication skills training, and some of us have also done the European Certificate in Palliative Care. And we've been able to then put our input into the prognostic indicators group within the Trust, and also regional discussions on how we take this work forward. The thing that we're also able to do now is contribute to research in palliative care, because we have been keeping our data on our patients. So there is a study ongoing called FEPOD study, which is looking at frail elderly people on dialysis, and they've recently decided to add in a wing looking at conservative care, and we actually have all our conservative care data and patients already identified, so it's easy for us to contribute now to that research study once the ethics goes through on that. And these are just the resources that some of which I've referred to. So, thank you.
Thank you.